Seventh semester is what do you remember?
Third year.
Video closed.
No, video is there.
Video closed. हम लोग last time audio से करा. हम last time. Video closed.
No, I didn't close it. Your picture will be at the bottom. You don't need it.
Okay. I don't know. That's all.
Okay, I'll close it then.
Yeah. Started, no?
I'll just confirm it.
Yeah.
Good morning everyone. So today's topic is retained placenta. Here I will show about what is the retained placenta, what are the risk factors because of which retained placenta can be there, and causes and their treatment. So here we come. What is the definition of the retained placenta? What is retained placenta? The placenta is said to be retained when it is not expelled from the uterus with even 30 minutes after the delivery of the baby. So what is that? The placenta is said to be retained when it is not expelled even after 30 minutes of the delivery of the baby. Normally, within 5 to 10 minutes, the placenta will be delivered, or max to max within 30 minutes. But after 30 minutes, that's called as retained placenta. Normally, placenta is expelled in 3 stages. It first separates from the uterine muscle, then it descends into the lower segment of the uterus and vagina, and then it is expelled outside. Problems can occur at any of the stages. What are the risk factors why retained placenta happen? Previous retained placenta history, previous injury or surgery to the uterus, preterm delivery, induced labor, that is called as artificial labor, and multiparity. What are the causes? Placenta separated but not expelled. Simple adherent placenta. Morbid adherence of the placenta. Placenta accreta, placenta increta, and placenta percreta. These are types of the placenta retained. What are the adherents? Placenta accreta, placenta increta, and placenta percreta. Then constriction ring reforming cervix, full bladder, and uterine abnormality. Causes of retained placenta. Placenta separated but not expelled. The placenta may separate completely from the uterine muscle but may still retain inside the uterus. There are 3 causes for the retention. Failure of the woman to push out the placenta due to exhaustion or prolonged labor. Closure of the cervix, preventing the placenta from being expelled. A constriction ring in the uterus can hold up the placenta. These are the factors where placenta separated but not expelled. This can be happened. Why not expelled? Then simple adherent placenta. Placenta may fail to separate completely from uterine muscle due to lack of contraction of the uterine muscle. This condition called as uterine atonicity occurs in cases when uterine muscles have become lax either due to repeated pregnancy, prolonged labor, or overdistension of uterus during pregnancy, as in twin pregnancy. Simple adherent placenta is the commonest cause for the retention of the placenta. Here next we will come to morbid adhesion of the placenta. Morbid adhesion of the placenta can occur when placenta is implanted deeply in the uterine muscle and this fails to separate. The placenta can burrow up to different depths in the uterine muscle. In simple cases, it is only attached firmly to the muscle and can be stripped off by hand. In severe morbid adhesion, placenta can burrow through the full thickness of the muscle. In this case, uterus may be needed to remove to control the bleeding. There are 3 types of morbid adhesion of the placenta as previously mentioned. placenta accreta, placenta percreta, and placenta previa. Placenta accreta. In this condition, placenta penetrates deep into the uterine endometrium and reaches the muscle but does not penetrate into the muscle. Understand? Placenta penetrates deep into the endometrium and reaches up to the muscle but does not penetrate in the muscle. Then placenta increta. The placenta attaches even deeper into the uterine wall and penetrate into the uterine muscles. This is placenta increta. And placenta percreta. In this condition, placenta not only penetrates full thickness of the uterine muscle but also attaches to another organ such as bladder or rectum. Placenta percreta is very rare. Risk of retained placenta. There may be a severe bleeding which may be life-threatening. Attempts at manual removal of the placenta can cause multiple injuries to the mother, such as like vulval hematoma, perineal tears, cervical tears, and vaginal wall tears. So here we comes at the management details. If the placenta is undelivered after 30 minutes, consider emptying bladder, breastfeeding, or nipple stimulation. Change of position. Encourage on an upright position. If bleeding, immediately inform anesthetist. Insertion of large bore IV cannula. Insert urinary catheter. Continue oxytocin infusion 20 units in 1 liter rate as a 60 drops per minute it should go. Measure and accurately record blood loss. Huh? Hindi please. Dr. Tejashri, OBGY department. Measures and accurately record blood loss. Prepare and transfer patient to theatre for manual removal of the placenta. Treatment will depend on the cause of the retention of the placenta. If bleeding is present, active treatment is done to control the blood loss and support the general condition of the patient, followed by control cord traction. If the placenta is separated but not expelled, then control cord traction should be carried out. In this method, the uterus is held in the place and pushed up gently through the abdominal wall. By the left hand, the cut umbilical cord hanging from the vagina is held in the right hand and pulled steadily and slowly to pull out the placenta. Like this, what the picture shows, the left hand will be over the abdomen on the uterus, will be pushed upward, and the right hand will hold the umbilical cord and slowly it will pull down. What is manual removal of the placenta? The placenta may be removed manually if control cord traction fails. The patient is put under general anesthesia in operation theatre under all aseptic condition. The sterile gloved hand of the doctor is inserted into uterus. The placenta is stripped from the uterine muscle gently and brought out. This is the picture showing how manual removal of the placenta is to be done. Introducing one hand into vagina along the cord, supporting the fundus while detaching the placenta. Withdrawing the hand from the uterus. Hysterectomy. If the placenta is too deeply embedded into uterine musculature called placenta accreta, a hysterectomy to remove the uterus may be indicated. So, first in a management, we will see first anti-shock briefly. Anti-shock treatment. If bleeding still not subside, placenta doesn't remove, then control cord traction. If control cord traction fails, then under all aseptic condition, under general anesthesia, we will do manual removal of placenta. And if it is deeply embedded into musculature, uterine muscles, then we have to do hysterectomy as well. Then post-procedure care. Observe the women closely until the effect of IV sedation has worn off. Monitor the vital organs, pulse, blood pressure, respiration every 30 minutes for the next 6 hours or until stable. Palpate the uterine fundus to ensure that uterus remains contracted. Check for excessive lochia. Continue infusion of IV fluids. Transfuse as necessary. Complication of the retained placenta. Uterine inversion may happen, shock, hypovolemia, postpartum hemorrhage, puerperal sepsis, subinvolution, and hysterectomy. Thank you guys. As per the topic is very short, so I'm overing and